I welcome everyone to our webcast, Survive the Ride Motorcycle Education Injury Prevention Program. The University of Miami Ryder Trauma Center, CUTR at the University of South Florida, Holmes Regional Hospital, and Lakeland Regional Medical Center would like to welcome you to the Survive the Ride Motorcycle Crash Pre-Hospital Provider Education Program. This program is a tertiary prevention project that is part of the Trauma Center-based Survive the Ride Motorcycle Education and Injury Prevention Program funded by the Florida Department of Transportation. This education module has been presented to numerous EMS agencies throughout the state of Florida and is now being offered today as a webcast during EMS Week as suggested at the recent EMS Advisory Council Medical Care Committee. Dr. Joseph Nelson, the Florida State EMS Medical Director, has granted 2 hours of CEU credit for those who participate completely in this module. We got to go down. Oh, wait, I got it. Wait a second. My name is Patricia Byers, and I'm the PI of the Survive the Ride Motorcycle Safety Program at the University of Miami Ryder Trauma Center. There are many people to thank today who helped make this webcast possible. I would like to first give a special thanks to CUTR at the University of South Florida for hosting this webcast, including Jennifer Eiley for all of her technical assistance, and to Kristen Larson and the team at CUTR for their assistant in data, Dr. Lin and Dr. Chang-Young Lee. I would like to give a special thanks to Tara Irani for all of her work behind the scenes in coordinating this effort, for the participation of Holmes, Lakeland, trauma centers, and to the Florida Department of Health, especially Rebecca, for helping us advertise this program, and to the Florida Department of Transportation for their vision in sponsoring this event, Trenda McPherson and Edith Peters. And a special thanks to all of our paramedics, telecommunicators, and pre-hospital professionals who all make Florida a safer place. Now I'd like to introduce to you Jennifer Eiley, who is coming to us from Tampa, the training and support specialist from CUTR, to go over the technical aspects of our webcast today. I again would like to thank her for all the support and training that made this presentation possible and to get me through this, since I am not a very techno-savvy person. Go ahead, Jennifer.
Thank you, Dr. Byers, and good afternoon, everyone. I'd just like to give you a brief overview of some of the tools in live meeting that you may find helpful and enhance your webcast experience. The first one is in the upper right-hand corner. Look for the icon that looks like 3 sheets of paper. You can download the group attendance sheet, and you can also download slides with the CEU instructions. If you prefer to view today's webcast in full screen mode, the easiest way is to use the F5 key on your keyboard. So F5 to enter full screen. When you're ready to exit full screen mode, simply use the escape key on your keyboard. If you have questions at any time during the webcast, you can type in your questions in the Q&A. Click on Q&A in your top menu bar, and then type your question in the white box and click the Ask button. Toward the end of the webcast, we will have a Q&A session where our moderator will ask your questions and you'll be able to hear the presenters answer them. If you're having trouble in today's webcast and you need some assistance, please use the feedback button also in the upper right-hand corner. You can change the feedback button to a different color to signal us that you need some assistance. We'll send you a chat message to hopefully resolve your problem. And now I would like to introduce to you Dr. Peter Pappas, coming to you today from Melbourne. Dr. Pappas is our moderator for today's webcast. He's a trauma acute care surgeon and surgical intensivist with the Trauma Center at Holmes Regional Medical Center in Melbourne, Florida. He has an active interest in telemedicine research, medical education, and injury prevention. So, Dr. Pappas, I turn it over to you.
Well, thank you, Jennifer, and thank you, Dr. Byers. It's certainly a privilege and a pleasure to be with all of you today and talking about this extraordinarily important topic. It's very important to emphasize here that clearly Florida is a state that is very high on everyone's list when it comes to motorcycle trauma. And it's also very important to mention as well that really for one of the first times what we're doing here is looking at motorcycle injury specifically as in terms of its unique mechanisms of injury and its unique presentations in the field. And I think that's a very important take-home message for everyone today. The presentation today will be broken up into two parts. Dr. Patricia Byers and Chief Corey Richter from Indian River Fire Rescue will do a presentation on mechanism and manners of injury in terms of motorcycle trauma, and then we'll also have two case presentations to follow. That will really sort of reemphasize the importance of how subtle these injuries can be. I'd also like to go ahead and certainly thank Dr. Ola Sobowale and Dr. Ernest Block for joining us as well. Dr. Sobowale is the Trauma Medical Director at Lakeland Regional Medical Center, and Dr. Block is our Director here at Holmes Regional Medical Center. In terms of housekeeping issues today, I'd like to keep in mind that all participants should have individually completed the registration form with the pre-survey questions. The lead educator for any group viewings must submit an attendance roster to Tara Irani at tarairani@med.miami.edu. And that's at TIRANI at med.miami.edu. And these are for participants in order to receive credit, as only one IP address will register electronically. So again, it's important for that to happen. The post-survey will need to be completed and submitted individually to receive CEU credit. Today's presenters are, as I've already mentioned, certainly Dr. Patricia Byers, myself, Chief Corey Richter, Dr. Olumide Sobowale, Dr. Ernest Block, Corey Richter, Jr., who is a flight medic with Martin County, Ms. Julie Bacon, and as well Dr. Joe Nelson. And at this point, I'd like to go ahead and introduce our queen bee, as it were, Dr. Patricia Byers, the leader of this project in many aspects, and really, I think we all are, certainly owe Dr. Byers a great deal of gratitude for bringing this project to fruition after a great many efforts, after a long period of effort. And with that, I'd like to turn it over to Dr. Byers to start our review of both the manners, mechanisms, signs, and symptoms of injury of motorcycle trauma and what is clearly unique to motorcycle injury. Dr. Byers.
Thank you very much, Peter. Thank you all for participating in our EMS Week special webcast today, Survive the Ride Motorcycle Crash Pre-Hospital Provider Education Program. We hope that you're able to learn something today about the field of prevention, as well as some practical aspects of pre-hospital assessment and care. We have our learning objectives today, which encompasses both my part and Corey Richter's part of the presentation, and we hope that you understand the magnitude of motorcycle crash injury burden in Florida and to gain some insight into what makes up prevention program components. We also would like you to come away to being able to appreciate the difference in injury risk in motorcycle crashes compared to motor vehicle crashes, and to know the risk factors that contribute to motorcycle crashes. We also would like you to learn about the different types of motorcycle collisions and the mechanisms of blunt injury that may occur and how they may affect triage decisions, and to review some of the basic and advanced skills for patient stabilization and assessment. Now, this is a slide that shows some very popular actors, Marlon Brando, Peter Fonda, Jack Nicholson, and Dennis Hopper. But this slide really highlights how the motorcycle has been romanticized in American culture, while in other countries it is regarded more as a mode of transportation. Today, with more and more people turning to motorcycles as a primary mode of transportation, we must begin to focus more on safety issues. There is a perception that we have a problem in Florida, and from this map of the state of Florida with the red star hot zones, you can see that we do have a problem. These hot zones have been mapped out by CUTR at the University of South Florida, and you can see that we have an especially high zone of injury in Miami Beach. Now, the important thing to realize that in 2008 to 2009, motorcycle fatalities reached an all-time high in Florida and made up 18% of all traffic fatalities, while motorcycles only comprise 6% of this traffic. So that came to the attention of the Department of Transportation, and the Motorcycle Safety Coalition was formed, and a comprehensive prevention program was put into place. Now, all comprehensive prevention programs must incorporate the 5 E's into the development of their prevention strategies. The 5 E's are education, which in this case includes rider education, patient education, physician and pre-hospital education. Engineering is a road engineering projects, for example, making road surfaces safer for motorcycles. Enforcement, motorcycle endorsements were legislated in order to improve education of motorcycle riders. Evaluation is evaluation of the projects. Statewide, after 2009, there was a decrease in mortality. And encouragement is to encourage all stakeholders who have any involvement to be involved in the solution of the problem. So today we're going to incorporate 3 of these E's, which is the education component today, the evaluation, which you're helping with, your pre and post surveys to see the effectiveness of this program, and encouragement as the pre-hospital system is a stakeholder in the solution of this problem. The Survive the Ride program is a Florida Department of Transportation sponsored program that is trauma center based. It has a secondary prevention component that reaches patients who have already been injured in one motorcycle crash, and a tertiary prevention component to help decrease the impact of injury by giving pre-hospital education and hospital-based education about assessment, treatment, and triage. When we look at prevention programs, there are 3 major types of prevention programs: primary, secondary, and tertiary. Primary programs focus on the prevention of the event itself. For example, the prevention of the crash. An example of this would be the Look Twice, Save a Life billboards that you see up for motorcycles and for drivers of cars so that they notice motorcycles. Secondary programs focus on the prevention of recurrent events and recidivism. So that patients are educated after having an injury to prevent subsequent events with increased awareness of safety, education, and other interventions. Tertiary programs, on the other hand, focus on decreasing the impact of the event so that we can decrease the disability and mortality from injury. For example, our training today. So our goal is to partner to decrease motorcycle fatalities. This is a form of tertiary prevention, mitigating the effect of the injury itself. And we hope to do this with expedited triage based on mechanism and injury patterns, directed pre-hospital therapy, and goal-directed transport to trauma centers based on high suspicion. The goal of this training is to form a common baseline of knowledge and awareness to allow partnership between the EMS community and the trauma centers to expedite triage and treatment of motorcycle crash victims so that we can decrease the burden of injury, of disability, and mortality. Now, although motorcycles are built to be very agile, being in a motorcycle crash is associated with an 80% chance of injury or death, which is, of course, much less than for motor vehicles where there's only a 20% chance of injury or death. If we consider 80% as a positive triage rate, this would ordinarily be considered highly specific. However, if those of you that can remember, at one time Florida had an ejection for a motorcycle as a mechanism of injury triage criteria. However, there were tremendous problems associated with this in terms of interpretation. Today, we depend on the physiologic and anatomic criteria that are used, and we depend on paramedic judgment, which is reserved for those patients that may have occult injuries. The trauma system currently is depending on paramedic judgment to prevent under triage, and today we'll delineate injury patterns that can help you in that decision making. Now, if you look at motorcycle crashes, most are multifactorial, predictable, and preventable. We should not refer to crashes as accidents, as in almost all cases, when we evaluate the causation, we find that there are multiple causes and problems. And if we considered those problems in advance, the crash could be predictable. In addition, if the causes had been corrected or prevented, the crash probably could have been prevented. And in motorcycle crashes, there are 4 major categories of risks, and we try to teach these to motorcycle riders so they can learn to minimize their risk of riding. For example, what would you consider to be a rider-related risk? One example is inadequate training, inadequate experience, alcohol ingestion. What would be the risks that you would think are related to other motorists? Well, we know about distracted driving and texting, driving under the influence, elderly drivers, and young drivers. What about environmental risks? There's construction debris, rocks, bridges with odd pavements and wet pavements. And occasionally there's equipment failure that include different parts of the bike that actually fail, steering, tires, or the rear brake, for example. Now, the next set of slides will demonstrate to you why Florida has had the perception of having a bigger problem than the rest of the United States. If we look at Florida, Florida has a higher percentage of motorcycle crashes compared to motor vehicle crashes when compared to the national average. And this separation has been increasing coincidentally with the repeal of the mandatory motorcycle helmet law in the year 2000. Now, others explain this by the fact that Florida has increased registrations and a 12-month-a-year riding time, which increases our exposure to crashes when compared to many other states that only have a few months where riding is possible. If we look at the percentage of motorcycle fatalities to all vehicle crash fatalities, they reached an all-time high in the year 2008 with a 17.8% fatality rate. And as you can see again, that this separation of this increasing fatality rate separated from the U.S. in 2000, coincidental with the repeal of the mandatory helmet law. If we look at the percentage of motorcycle fatalities to all motorcycle crashes, again we see there's a separation in the year 2000, and that Florida has a higher percentage of fatalities compared to crashes when compared to the United States. Again, this is coincident with the repeal of the mandatory helmet law in 2000. Now, this is a slide that shows what an evaluation of an intervention. In 2008, the motorcycle endorsement became mandatory on July 1st. And you can see here that if we look from 2008 to 2009, in all categories of fatalities in purple, hospitalizations in green, and emergency department visits in yellow, there was a decrease in these after the institution of the mandatory endorsement. Now, many people feel there is a perception of motorcycle tourism in Florida, but this slide clearly demonstrates that 90% of those injured or killed in motorcycle crashes in Florida are actually Florida residents. As you can see in this slide, with purple being Florida residents and yellow being the small percentage of non-Florida residents. Again, this next slide looks at the effect of the motorcycle endorsement in July 2008, broken down by Ryder age group. And if you look at these slides from the age group of 21 through the age of 45 to 54, you can see that from that period of time, in those age groups from the year 2008-2009, fatalities decreased across all the age groups, except for those riders that are greater than 55 years old, where there didn't seem to be much of an effect. It is unknown why this is the case in this particular age group. Some feel that it may be due to the fact there is less education because there's some grandfathering in without actually taking the basic rider course to gain an endorsement, or it may be due to the higher risk of mortality from crashing in this age group. Now, if we look at the monetary burden of this, there's a significant burden of health care costs to our state due to motorcycle crashes. In 2009, there was almost $4 million spent in hospitalizations of patients injured in motorcycle crashes, and emergency room visits were almost $50 million. Now, this is just the tip of the iceberg, as it does not take into account the years of life lost, any pre-hospital expenses or costs, or any rehabilitation or long-term care costs. when you take into account and compound on top of that over 40% of motorcyclist hospitalizations and visits are not covered by commercial insurance, and up to 30% of patients are underinsured or self-pay, this is a tremendous economic burden to our state. Now we're going to look at the different types of common motorcycles. In addition to the scooters, which are defined by a less than 50 cc engine, there are 4 common types of motorcycles. There's a sport bike, which are most commonly ridden by younger riders that go at higher speeds and actually wear a full helmet and full gear. The next 2, the cruiser and the touring bike, usually are ridden by older riders at lower speeds. However, they definitely use less gear and less helmets. And then the standard bike, which is used across all age groups and is the most common type of bike used for transportation. Now getting into the injuries, we can look at the mechanisms of injury by blunt trauma are mainly 2. The most devastating injury can be a shear injury, when patients experience rapid deceleration from a high-speed injury and they come to a rapid halt. In this situation, internal organs or parts of internal organs tear. And a very common example of this is diffuse axonal injury, when the brain tears inside the skull without really having an external force as responsible for the injury. So this injury can occur even with a helmet on in high-speed crashes. This is often results in extremely devastating long-term severe brain injury. The thoracic aortic injury is also seen to the example there on the right. You see a little arrow with an outpouching. This shows where the aorta tears off the ligamentum arteriosum when the heart is pulled forward and the aorta is tethered by this ligament. And this actually can spontaneously rupture, causing exsanguinating bleeding, or it can actually dissect and rip the aorta down its entire length. Other injuries that can occur from shear can either be injuries of the vessels of the renal vessels, or it can be any intestinal vessels as the force of the intestine and kidneys are pulled forward, tearing their vascular pedicles. Next, I would like to talk to you about compression injury. Compression injury is when the patient is crushed or squeezed between 2 objects. A very common injury that is seen secondary to compression is the open book pelvic fracture. That is the photo that you see to the right of the pelvis. As you can see that the pelvis opening in the front is extremely widened and the back of the pelvis is very irregular. The back of the pelvis is lined by very large veins, at least the size of your pinky finger, and when these tear, due to tears in these joints, there's quite a bit of hemorrhage that can occur. In addition to that, in the front of the pelvis, where you see the large separation, there are arteries running, and these arteries bleed profusely and cannot really be easily managed with surgery and need angiography and angioembolization to control the bleeding. Another type of compression injury are contusions, most commonly of the heart and lungs. As you can see in the bottom slide on the right-hand corner, there's kind of an infiltrate in the right lung, a white area, where there's been bleeding into the lung air spaces. This prevents the exchange of oxygen and carbon dioxide and results in what's called a pulmonary contusion that may not manifest its worst stage until 1 to 2 days following the injury. So this is an example of an occult injury that the patient may find on the field and develop much worse findings as they stay in the hospital. You can also have rupture of the intestine, spleen, and liver when there's compressive injury. If we look at the 3 types of motorcycle collisions, one type of collision is the head-on impact. And especially with the head-on impact, patients are usually ejected and launched over the handlebars. This causes a primary injury of the patient against the bike, and especially with the wider bikes, it's very common that we see this compressed injury of the open book pelvic fracture with the pelvis actually widened and split open. Also, you can get prime injury for actually hitting something else in addition to the bike. So there could be brain, chest, abdomen, pelvis, or femur fractures depending upon the impact with the handlebars and what other object. Secondary injury is from the ejection and landing on whatever object after being ejected. These injuries can be a combination of shear and crush injuries as the patient does come to a rapid halt, and depending upon the circumstances and what they actually hit. Again, multiple injuries are common, including brain, trunk, extremities, pelvis, and other fractures depending upon the distance launched. The second type of motorcycle crash impact is the angular impact, where the patient is crushed between the motorcycle and an object. Obviously, in this situation, the extremities are most vulnerable and get injured most commonly. We have seen these injuries brought to us at Ryder, where the rider gets trapped between the bike and the guardrail, and the guardrail has occasionally caused a traumatic amputation, and the patient and their leg come in separate packages. The third type of crash is when the rider, who's maybe more experienced, sees something coming and avoids a crash by laying down the bike. The severity of injuries incurred by this will depend upon the amount of protective gear that is in place. As you can see on this slide to the right, provided with the courtesy of Dr. Pappas, this particular rider laid down his bike in flip-flops, which at the great harm to his foot and lower leg. Hand and extremity injuries are very common, and open fractures that have to be taken to surgery urgently are very common from this type of crash. Now I would like to present to you Corey Richter, who's been in the EMS field since 1983 and currently holds the position of Battalion Chief for Indian River County Fire Rescue. He is very active at the state level, where I met him, where he works on various injury prevention committees and is active in the legislative process for EMS and fire rescue issues. Corey is the current chairman of the Florida EMS Advisory Council and the Strategic Plan, and has been instrumental in promoting injury prevention programs throughout Florida, and is the past chairman of the Florida Public Injury Education Relations Committee, well known to us all as PEER. Corey comes to us today from Vero Beach.
Thank you, Dr. Byers. Great introduction. I'm going to start with triage of motorcycle crash victims and cover some of the injuries and treatments associated with motorcycle crashes. And first and foremost, you must be familiar with the state trauma triage criteria. There's 5 red, which means five of those, you only have to meet one of those criteria in order to be a trauma alert patient. The blue section, you have to meet 2 or more of those. For motorcycles, probably almost any of the red could be applicable for a motorcycle, either active airway, lack of radial pulse, 2 or more long bone fractures, amputation proximal to the wrist or ankle, or penetrating injury, or paralysis. Any one of those could apply to a motorcycle injury or crash. And the blue, probably the more common one that you're going to see there would be respiratory rate greater than 30 and heart rate sustained greater than 120, or the best motor response of 5. But they'd have to meet 2 of the blue in order to meet the criteria for trauma alert. Also, check your local trauma triage criteria, your TTPs. Your agency may have something above and beyond the state criteria that would allow that patient to meet the trauma alert criteria. What we're going to be talking about, too, is paramedic judgment, because we want to bring that into play here and make people aware of having to do a good assessment on a motorcycle patient. A lot of times they will not present. They're either real obvious because they have devastating injuries and they're unconscious, unresponsive, and you know it's a trauma alert, or they're the ones that we're really talking about are the ones in between that are maybe up and even could be walking around or awake and alert. And a lot of motorcycle riders are tough guys or gals, and they don't want to be treated, and they may be denying injuries. So on first glance, they may appear to be, not as injured as they could be. They can be some of the more complex patient assessments that you'll have to do, and so you have to do a complete head to toe in order to find any injuries that may cause them to be a trauma alert. Now, with paramedic judgment, you could consider a single long bone fracture just because the mechanism alone, if they had that to get a single long bone fracture, you could consider that. You have to take into consideration a good assessment and anything else that you may find. But what you also have to take into consideration is any protective gear that they were wearing. Speed of the motorcycle, how fast were they going? Is it on a highway or around town? And even around town, just because the speed limit's 30 doesn't mean they were doing 30. Helmets and leathers, are they wearing leather gear or protective shoes or anything? The slide that you saw just before with the guy that was wearing flip-flops, you see that's a pretty devastating injury to his lower leg, and all because he didn't have any protective gear on. So, of course, the mechanism for a long bone fracture, sometimes they may not be displaced, may not be obvious. You may have to that's where you got to do a good hands-on to find the injuries. One thing you got to look out for is any distracting injuries. Some obvious deformities or road rash can be distracting, and you may not be doing a good assessment on that patient and good head to toe and checking for other injuries that the patient may have. Pelvic injuries are one of the most common next to the shoulder injuries for patients, so you have to do a good pelvic thrust, check the pelvis area, palpate it very well to see if they do have a pelvic injury that you may not be able to tell immediately by looking at it. The pelvic injuries are not generally going to be deformed. It's not going to be obvious, and the patient may or may not be complaining of pain in that area. So you have to do a good assessment to detect that. And of course, with rib fractures, there's a high correlation to internal injuries with that. So if they've got pain in their chest area, suspect and be aware that there may be underlying injuries to the organs that they're under there, the spleen, the stomach, the liver. All of those are protected partially or all by the ribs and have a high incident of injury. And then injury patterns, orthopedic, the shoulder and pelvis, again, they're most at risk. The shoulder because they'll fly off the bike onto their shoulder, the pelvis because they land on their pelvis or they hit it on the handlebars on the way off the bike. And then, of course, road rash. Road rash can be very dangerous for the patient because of the lack of protection now to the body. And even in Florida, you have to be careful about hypothermia. Patients will get hypothermic, especially if they've got a lot of road rash. They have no insulation left anymore. That's what the skin, being the largest organ in your body, protects your body from outside organisms and heat and cold. And if they've got a lot of road rash, it may look, kind of look bad, but you got to keep them warm. And of course, facial injuries, a lot of riders will ride with just a skull cap or no helmet at all. But even with a skull cap, they could have severe facial injuries because there's nothing protecting their face unless they've got a full helmet on. So you have to be aware of that, and of course that's going to complicate your airway and make normal airway procedures difficult at best to do. With traumatic brain injury, the main goal there is to keep the BP above 90 or right around 90. You don't need to keep it any higher than that. You don't want to give any more fluid than what's needed to maintain a systolic of 90. And the pulse ox, you want to try to keep above 95%. If they get hypoxic and associated with a head injury, it dramatically increases the fatality rate for that. So you really don't want to let that patient get hypoxic. Do everything you can to keep them oxygenated. As you can see on this slide, It shows the percent of injuries that are fatal and their associated AIS score, which is abbreviated injury scale. The scale runs from 1 to 6, 1 being minor, 6 being non-survivable. And what this is looking at is anything above 3, which is severe to critical to non-survivable. So you can see the head and chest are high up there in the percent of injuries, chest being the highest percentage, but the head, even though it's just below it at 73%, but 56% of them are fatalities. So you really have to be aware of looking for the head and chest injuries more than anything. They're the most critical, and you can see the highest rate of fatality as far as motorcycles are concerned. And then you got the abdomen, the spine, and extremities have a lower incident of fatality in relation to motorcycle crashes. And that's not to say that you don't want to pay attention to them or those areas. You just want to be acutely aware of the head and chest as far as when you're doing your assessment. Now, stabilizing motorcycle victims with the airway. Severe brain injury, again, that can severely compromise your airway. Either they won't be able to breathe on their own because they don't have the brain function to do it, or like the picture in the top right, he's got severe facial injuries there that are going to severely complicate your airway, and your normal airway and airway adjuncts are probably not going to be able to do. Of course, nasal intubation is going to be contraindicated in any patient with a head injury, because you don't want to intubate into the skull. You're probably going to have to do a cricothyrotomy. Probably the hardest part of doing a cric is making that initial decision to actually do it. Once you get past that decision and do it, it's a very easy procedure, common procedure, and you either do the cric or you have the needle cric, depending on what your protocols are. And you just follow your protocols and do it. A patient like that, you'd want to do it as quick as possible because you want to keep him oxygenated. You know he's got a head injury and pretty severe facial injuries there. Motorcycle helmets should be removed unless your protocols don't allow it. If they don't, you may want to address this with your medical director or your training division and see if they can't change that. Both ITLS and PHTLS have great training sections in their program for removal of helmets. You can query other agencies and get their protocols on removal of helmets. It makes C-spining them a little bit easier, and of course addressing any airway problems, it'll make it a lot easier, especially if it's a full helmet. It's very difficult to assess the airway and maintain a good airway with the helmet on. So hopefully you do have the protocol to remove a helmet, and that way you'd be able to take care of the airway a little bit better. Most motorcycle crashes, they do have a high incidence of cervical spine fractures, so you really want to, when you do remove the helmet, remove it without manipulating the C-spine. Try to manipulate as little as possible. And now breathing. Again, patients may not be able to breathe due to the brain injury, so you want to ventilate for them. You're going to start off with, if they're breathing on their own, you can non-rebreathe fine. Otherwise, go right to bag valve mask, and then secondary airway, whether it be intubation, LMA, King, whatever your agency has and your protocol allows you to do. You want to do something to maintain and secure the airway. Again, like we talked about before, rib fractures. They're very common. What you have to watch for with those is the tension pneumothorax and hemothorax and lung contusion on that. Keep checking the lung sounds. If you start hearing diminished lung sounds on one side, decompress. Don't hesitate, because that patient's going to start getting hypoxic again because the tension will decrease the amount of oxygen they're getting on that side. They'll also start pushing on the major organs. Also with the rib fractures, you have a high incident of liver and spleen injuries. So you need to do, again, a good assessment on them, and that'll help you. The circulation, again, pressure dressing to the scalp, just you don't want to do direct pressure. You're just going to want to just put a tight bandage around it, keep adding bandages if you need to, and that's it. For other bleeding, finger point pressure, direct pressure, you can use that. That will stop most bleeding. If you have extenuating injuries, then you can use a tourniquet. And if you don't have a protocol for a tourniquet, you should, again, look at that. The state EMS website, they do have a draft of a tourniquet protocol that you can use as a reference, and query other agencies around you that may have one. Because a lot of tourniquets are back in for extenuating bleeding and stuff. It does work. Unfortunately, at the cost of our military, that's how they found that out over in Iraq and Afghanistan. But tourniquets are saving lives over there with if you have catastrophic injuries to extremities, and so they really do work well. You just want to place it about 5 centimeters proximal to the bleeding or the amputation, and make sure there's no distal pulse once you've tightened it up. Don't loosen it until you get to the trauma center and or hospital. Hopefully it's a trauma center. Let them take care of loosening it. As far as the pelvis, you wrap the pelvis with a binder or sheet for long transports. If you've got, they do have commercial wraps for the pelvis. If you have those, that's great. If not, you just wrap it in a sheet. What you're trying to do is just keep it stable and stuff. Just on the backboard is not going to stabilize the pelvic fracture. And we talked about not giving excessive fluid. You want to just keep that systolic blood pressure right around 90. That's all you need to do. Any more than that, you're giving them too much fluid. And then disability. Glasgow coma, anything under 13, and you should be considering the trauma alert. Anything under 9, and you should seriously be considering either endotracheal tube or an alternative airway for LMA or King or whatever your agency allows for an alternative airway there. Certainly bag-up mask at the very least, for if it's Glasgow is less than 9. They do have a high risk of cervical spine and thoracic spine injury, so you want to maintain that C-spine and collar and back boredom at all times. Of course, the environment, you want to keep the patient warm and dry. Even in Florida, you got to think about keeping them warm. You may be all hot and sweaty because it's a serious call, but that patient, if they're losing fluid, whether it be internally or externally, they will get cold, so you need to keep them warm. Once you've clipped and stripped and checked everything for any further injuries, make sure you cover them up with a blanket as soon as possible to maintain their environment. They'll likely need blood transfusion. Of course, the agencies, we don't carry it. Some helicopter agencies do carry it. If you're calling a helicopter, they can give it. But you just want to maintain that 90 systolic blood pressure. You've got a high risk of hypothermia and with coagulopathy, which means their blood is unable to coagulate because it's lost so much blood now, and you're adding fluids to it, which has no coagulation therapy or disorder. So if you have warm fluids, you want to use warm fluids. I know that's difficult in the pre-hospital setting. We don't have warmers. We may have refrigerators for hypothermic protocol, but you don't have anything to warm the fluid. But you do whatever you can to help keep the patient warm. And the last thing, transport to the trauma center. That's very important, notifying the receiving hospital regarding the status. When you do that, you want to paint a really good picture. Of course, your initial notification should be through your dispatch, if that's your protocol for it, at least that they at least warn the trauma center that somebody's coming, and then on your way you'd give a radio report. And when you give that radio report, you want to paint a good picture for them so that they can have an idea of what's up with that patient. Are they going to need OR? Are they going to need neuro? Are they going to need ortho, et cetera? So will they need a chest tube, stuff like that. That's what the more information you can give them, the better for the trauma center and the trauma surgeon, so he can make a more informed decision prior to the patient getting there. All right, this time, we want you to just send any questions, send it up in the Q&A section up in the top, all right? If you have any questions, we'll address them as many as we can at the end of the 2 case studies. And right now, it's my distinct pleasure. I'm going to turn it over to Dr. Olu Sabawali, who will be presenting the case studies. All right.
All right. Thank you, Corey. We're going to discuss 2 cases of motorcycle crashes where paramedic judgment was used to triage patients to trauma centers. We'll start out with case 1. That will go up to Dr. Ernest Block. Dr. Block is presenting for us today, and he's the medical director for Level 2 Trauma Center at Holmes Regional in Melbourne. Dr. Block received his medical degree from University of Miami and general surgery in Einstein in Pennsylvania, in Philadelphia, Pennsylvania, and then additional trauma and critical care back here in Florida at the University of Miami. He's the past president of the Eastern Association for the Surgery of Trauma, the vice chair for the Florida Committee on Trauma, and the president of the American College of Surgeons Florida chapter. And in 2002, after practicing for 10 years as a surgeon, Dr. Block attended night school to become an EMT to better relate to the pre-hospital team that brings the trauma center its patients. He also got a master's in business administration from the University of Tennessee in 2007. So as you can see, he's a very well-read person and very well-rounded. And Dr. Block, take it away.
Thank you very much, Dr. Sabawali. Pleased to begin with this presentation. This will be patient number 1 from Holmes Regional. This is a 42-year-old female rider of a motorcycle. She was an off-duty law enforcement officer. She was riding her motorcycle, which was struck from the right side by another vehicle. She was thrown from the motorcycle. In terms of protective equipment, she was wearing a helmet. However, the remainder of her body was poorly protected. She had on a leather vest and a short-sleeve T-shirt and shorts. This will play into importance in terms of paramedic discretion and the patient's injury pattern. Palm Bay E1 was the first unit to respond. On their initial evaluation, her Glasgow Coma Scale score was 15. She denied any loss of consciousness, and she had no amnesia to the event. She was able to remember distinct details. However, of concern to the treating EMTs at the scene is she complained of abdominal pain, severe in nature. In addition, the treating team identified visible road rash to the extremities, particularly in the area of unprotected skin. The team immediately initiated a C-spine protection, including a longboard and collar, and a trauma alert was activated. Brevard County Rescue was alerted to transport the patient to the nearest trauma center, Holmes Regional. On arrival of Rescue 84 from Brevard County, Glasgow Coma Scale score remained at 15, respiratory rate was normal at 20, pulse was a little high at 92, and she was hypertensive at 152 over 112. Again, the patient had persistent right upper quadrant pain, right-sided chest wall pain, and otherwise lower intensity diffuse abdominal pain. She had the aforementioned road rash, but otherwise the exam revealed no obvious injuries. She was transported as a trauma alert to Holmes Regional Medical Center with spinal immobilization. The Holmes Regional Medical Center is a Level 2 trauma center. It serves as the only trauma center in Brevard County, 514-bed hospital, and considered the flagship hospital of what's called the Health First system. And we have a unified trauma acute care surgery center with surgeons available 24/7. On arrival to the trauma bay, the patient was found to be hypotensive at this time. She had taken a drop in blood pressure despite immediate initial stabilization by the field EMTs. She was more tachycardic than she had been. Because of the paramedic information that was delivered to the trauma center, we had a heightened concern for abdominal trauma, and our ultrasound machine and technician were, of course, immediately available. They performed a FAST exam, or focused abdominal sonography for trauma, looking for the presence of fluid in the abdomen suggestive of bleeding. This was in fact discovered, and what you're looking at, the image on the right side of the screen, is a CT scan of the abdomen. The red circle shows a devastating injury to the right side of the patient's liver. That's a dark area of tissue within the red circle. And then you also see some brighter areas within that dark area. That's called a blush, and it's consistent with active, ongoing hemorrhage. This patient was bleeding rapidly, was hypotensive, and was taken to the operating room. In the operating room, she was identified as having a grade 4 liver laceration. As Corey indicated earlier, the grading severity is 1 through 6, but if you exclude 6, which is a fatal injury, this is the second highest grade injury you can have. So a very serious injury. It was obviously hemoperitoneum, which was brought into a cell saver and transfused back into the patient. She also is identified as having rib fractures and a diaphragmatic injury on that time. At this point, damage control surgery was initiated. This is a technique that trauma surgeons have adopted from the Navy, in which the focus is to control the problem at hand without worrying about definitive management. So the liver is packed off as a compressive dressing, just as we do on external wounds, to control the hemorrhage, and then the patient was taken to the surgical intensive care unit for ongoing resuscitation and correction of coagulopathy. Because of the extent of the liver injury, it was presumed that this patient was going to have further devitalized tissue, and also with the packing in place, she was turned to the operating room 2 days later. A resectional debridement of the liver for necrotic tissue was performed, and at that point, the diaphragm was repaired. There was no urgency to repairing the diaphragm earlier. The focus, again, was on controlling the hemorrhage. And at that point, the abdomen was closed. This patient had a long ICU course manifest by infectious problems, as we often see in patients who have profound shock and intra-abdominal injury, but eventually she was discharged to rehabilitation and home, and is looking forward to returning to her role in the law enforcement community. So I thank you, the panel, for the privilege of discussing this case. I'll return it to Dr. Sobowale and the panel for any discussion.
Thank you, Dr. Block. Wow, that was a very exciting case, very fascinating. I mean, that's the kind of thing that makes trauma surgeons just get pumped up, ready to go when you see this kind of patient coming in. Now I want to turn it over to Dr. Byers, who's down in Miami at this point, and she's going to give us some commentary at this point. Dr. Byers?
Oh, again, I totally agree with you, Olu. That was a fascinating case presented by Dr. Block. And I think that I just wanted to reiterate the point of the incidence of chest tenderness and rib fractures in this case, that had there not been abdominal tenderness from the blood, it would have tipped off the pre-hospital provider that there could be internal injuries. So this is, again, a good example of that teaching point.
Great. Thank you, Dr. Byers. We have this kind of situation, and sometimes children are involved. And I'd like to see if Julie Bacon from EMS in St. Pete can give us a little bit of a perspective from the pediatric standpoint. Julie?
Yes, I appreciate that. You know, it's interesting, in the state of Florida, there are no rules governing how young a child can be to ride as a passenger on a motorcycle. even though we have them for riding in our cars. So I'd like to take a look for a moment at about how the assessment might change if it's a pediatric patient. In this case, imagine how much complicated the scene would have been if it had been a child. And the pre-hospital responders should know that whenever they treat a pediatric patient, there are a couple of very unique trauma considerations. For example, as compared to adults, children have very little protection to their chest and abdomen. The ribs are higher up in the chest. They're extremely flexible and bendable, and their abdomen is very large compared to their size. So in this case, had this been a child, an impact to the torso should trigger the thoughts of potential internal injury and bleeding, even without any sign of apparent rib fractures. And in addition, kids really hide their initial symptoms of shock better than adults. They compensate with pretty normal vital signs, and their presentation may look normal right up to the point where they rapidly deteriorate on you. So knowing those differences and dangers ahead of time can really assist the medic in making the best triage and treatment decisions. So that's something to consider.
Thank you, Julie. As with the expression we used to use about kids being stable until the fall off the cliff. So we need to keep an eye on those kind of situations. Coming to you from Pinellas County is Dr. Joe Nelson, the State EMS Medical Director, and he has some insights also to this kind of situations for us. Dr. Nelson?
Yeah, I just wanted to comment. I think this is an excellent example of the appropriate use of paramedic judgment. The pickup on the patient's chief complaint of abdominal and rib pain combined with a thorough assessment enabled an early trauma alert and transport to the appropriate facility, which in this case was probably life-saving for this unfortunate victim. So it was a good job by the EMS personnel on the scene.
Thank you, Dr. Nelson. We're going to move on now to the second case. This is actually a two-parter. We're going to start out with Corey Richter and then follow up with the trauma segment part with Dr. Pappas. Corey Richter comes to us from Hope Sound, and he's actually been kind enough to join us today from Mon County Fire Rescue. He's been with them since 2005 as a firefighter paramedic, and in 2008, Corey became a field training instructor for new hires and paramedics. He started teaching EMT paramedic school for Indian River State College in August 2008, and is currently functioning as a flight paramedic with Mon County Fire Rescue Aeromedical Program on Lifestar. Thank you for coming to join us today, Corey, and I think you have a good case for us to take a look at. Corey?
Yes. Thank you very much. We were dispatched to a motorcycle accident on the Florida Turnpike in Osceola County, and when we arrived, we found a 31-year-old female who was fully immobilized, who was the passenger of a motorcycle wreck. The lead crew medic from Osceola advised that she was calling a trauma alert solely based on the mechanism of injury for the patient. The patient was not wearing a helmet, had no loss of consciousness. GCS-15, upon arrival of the ground crew, complained mostly of generalized pain, throughout the body with more or less in the head and left ankle. No real deformities or anything noted for the patient, other than just a small hematoma on the head and a small abrasion on the left ankle. Patient again was, GCS-15, no loss of consciousness, a Ryder, high-speed velocity on a motorcycle, and they called a medic discretion trauma alert. We airlifted the patient from the scene to Holmes Regional Medical Center, where the patient remained stable during transport, no change in vitals, just continued to complain of that generalized pain all over. GCS remained 15, and arrived at Holmes Regional Medical Center, where we turned the patient over to the trauma center, and Dr. Papayas received the patient and will provide the further information for the patient after arrival at trauma center.
All right. Thank you for your time, and we're going to introduce Dr. Pappas at this point. Dr. Pappas is a trauma acute care surgeon at Holmes Regional, and he had his medical school and general surgery residence at the University of Miami-Jackson. He also did scholarship in surgical critical care and trauma at Orlando Regional Medical Center under the tutelage of, I believe, the amazing Dr. Block. He's board certified in general surgery and surgical critical care and has an active interest in telemedicine research, medical education, and injury prevention. Dr. Pappas?
Thank you very much, Olu, and thank you, Corey, for that great lead into this talk. This again, is a fascinating case where, as you'll see, paramedic judgment was crucial in making the right call. As Corey mentioned, on arrival to Holmes Regional Medical Center, the patient was with appropriate C-spine and backboard precautions. She had very similar complaints as in the field. While she denied loss of consciousness, she was somewhat amnestic to events. Her GCS was 15. She was awake, clearly alert, but agitated. Vital signs were stable overall, and as it was noted in the field, what we found initially, of course, was a scalp hematoma and pretty significant left ankle pain. As you can see here in these films, in part of our workup, what we did find actually after the patient had a CT brain C-spine performed was in fact an occipital skull fracture with a subdural hematoma. And you can see these yellow arrows pointing to it, subtle area of bright blood in the occipital area of the skull. And we also actually find a left calcaneus fracture of the ankle. And of note again, the findings in the field were fairly subtle. Again, just a scalp hematoma and complaining of ankle pain. But you add that to the mechanism and you come up with some fairly significant injuries. Management of this patient was certainly admission to a monitored bed where scheduled neurologic exams could be performed, as well as neurovascular checks on the foot. And she was evaluated by both our neurosurgery service and trauma orthopedic service. She progressed, fortunately without intervention, was discharged home on hospital day number 3 to outpatient rehab, as well as with an outpatient head injury evaluation for post-concussive syndromes. She remained non-weight bearing in the left lower extremity with follow-up in our orthopedics clinic.
Thank you, Corey and Dr. Pappas. That was an interesting case. Just looking at the subtleties of traumatic brain injury now, while not as exciting and dramatic as the first one, it still tells us that we've got to be on the alert, we've got to look out for these injuries as they apply and manage them and get these folks back out into the community. I'm going to ask Julie again to give us commentary on the pediatric side of this kind of situation from TAPR. Julie.
Well, thank you. You know, the only regulation that applies to a child who is riding on a passenger on a motorcycle is that they do wear an appropriate helmet. A lot of times, though, this is a helmet that's been borrowed from a relative and ends up being very little protection. Since the head of this child is disproportionately very large and heavy, any child that's thrown from a motorcycle most likely is going to go head first. And head injury should be the primary consideration anytime you approach a pediatric trauma. The assessment is going to be a little different than adults, and the first thing you need to be aware of is what is age appropriate for a child. For that age, what sort of command would they be following? What sort of questions would they be able to answer? The signs of a closed head injury in a child can really be very subtle. So if the medic keeps in mind this unique presentation of a child with a very large head, they're going to have that high index of suspicion of head injury, even if the child initially presents without really clear signs and symptoms. So that's something to keep in mind.
Thank you, Julie. Dr. Nelson from Pinellas, you have something for us on this issue also?
Certainly. Well, the first thing I'd like to say is this is another excellent example where paramedic judgment, picking up on subtle signs and symptoms, made for an appropriate disposition of the patient to a trauma center. In this case, the patient seemed somewhat agitated at the scene, and that can certainly be a sign of either early shock or a traumatic head injury. So again, an excellent job by the EMS personnel. One thing I wanted to mention was that on occasion, EMTs and paramedics are subject to some critical comments by trauma QA committees and things like that around the state when they institute paramedic judgment. And I would like to ask Dr. Pappas to comment on the trauma surgeon's point of view of the use of paramedic judgment.
Dr. Pappas? Dr. Pappas?
Yes.
Would you please comment on the perception sometimes that trauma surgeons and maybe ED physicians don't appreciate paramedics' judgment in this kind of situation? What's your take on this?
Well, I think we certainly all have, in a sense, stressful jobs, and we're all called upon to make decisions in a pinch. But oftentimes what I've found with paramedic judgment is that it can be an extraordinarily powerful tool. And I believe it's something that needs to be protected and nurtured. If anything, what paramedic judgment comes down to is learning how to make the right call at the right time in the field using your clinical judgment and trying to very rapidly assess that situation. What I've found, certainly in my own practice, and I think many of us in the field of trauma and emergency medicine can agree, is that as we advance through our own careers, we see that paramedic judgment is certainly a more important concept and something that is very something that needs to be sort of nurtured, as I said, protected and considered part of a paramedic's education. Learning how to make the right call can be crucial because we have to bear in mind that the manners and the mechanisms through which people can get injured are essentially infinite. No two patients are the same. No two traumas are the same. And you really can't write a protocol, no matter how detailed or how good it is, either on a statewide or national or local level, that will cover every possible eventuality. And that's my take on paramedic judgment, in the sense that I really think it's a very important adjunct, and really, in many ways, just as important, because you can think of it as adding into the human factor, as it were, and turning a trauma alert from more than just, checking off boxes on a list to putting in your own judgment as a clinician. And remember, at the end of the day, we all are clinicians, although we practice under different circumstances, and we're all, when it comes to trauma, certainly working together to make the best possible outcome for the patient. And oftentimes what happens in the field, the decisions made in the field, will really sort of set the tone for everything that follows.
Very interesting, very interesting. Very insightful, too, I would say, Dr. Pappas, because, I'm thinking about it from my standpoint that, we use the term discretion, but discretion kind of sounds arbitrary. This is actually paramedic judgment based on experience, visual at the scene, that comes into play as when that decision is made to call a trauma alert, even though all the criteria may not be inside of that one box. So I think you kind of hit the nail on the head about everybody working together, and everybody's got their roles to play inside of this inside patient care arena. I want to thank the panel for the interesting comments today, and Dr. Pappas, I think you're taking questions at this point.
Yes.
And okay, I'm going to turn it over to you for the rest of the presentation. Thank you, Dr. Pappas. You can take it now.
Thank you very much. And first of all, I certainly would like to invite everyone listening in and watching, go ahead and submit questions at this time. My name is Peter, and I'll be your host for this aspect of the talk, as it were. I feel like I'm on a radio show. The first question we have is from Jim. Hello, Jim, if you're out there. And this is a question really to the group that we have with us today, of course, all of our panelists, Dr. Byers, Dr. Sobowale, Chief Richter, Dr. Nelson. and Miss Julie Bacon as well. Jim's question is to all of you now. Have any studies shown that certain types of bikes offer their riders more protection? For example, a cruising bike that almost surrounds the rider. Does this seem to prevent injuries or lessen them? And we'll start off perhaps with Dr. Nelson, if you'd like to comment on that.
I don't know of any studies right off hand, but certainly the use of things like the protective bars on the side of some of the cruiser bikes, the more traditional long-distance cruising bikes seem to have some extra built-on protective mechanisms that I would think would lend itself to being safer. That being said, on the other end of the spectrum would be the commonly known as road rockets that have very little protection and are capable of extremely high speeds in relatively short distances, and when they are ridden improperly lend themselves to severe injuries or fatalities. So certainly the way a bike is built, the extra equipment that might be on that bike could provide protection or lack of protection depending on the bike.
Okay. And I think another thing that certainly was brought up in the presentations by both the excellent presentation by Dr. Byers and Chief Richter were that ultimately that motorcycles clearly were not created to protect a rider in general, and that they're designed more for transportation and for agility, not necessarily for survivability. So clearly another thing that's very important to bear in mind is that whenever you're dealing with a motorcycle rider, to have that heightened concern for injury is very important. Dr. Byers, would you like to add to that?
Thank you, Peter. I would. I think it's important to note that the industry is looking into some sort of trikes with roll bars for police, motorcycle police, because of the high risk of injury with motorcycles as they are currently built. The motorcycles do have some safety features that include things like anti-lock brakes and things like that take quite a bit of training for the rider to learn how to use. But generally speaking, the motorcycle as it exists today does not offer a lot of surrounding safety equipment for the rider.
Very good. And again, thank you for that question, and appreciate our panelists there. The next question is from David M. And Chief Richter, I'd like to have you start off with taking a stab at this question. Are there any model local protocols to supplement state trauma alert protocols with regard to motorcycle crash as a mechanism of injury? In other words, does any particular jurisdiction really do trauma alerts well in terms of guidelines when it comes to motorcycle trauma?
That's a good question. I'm not sure. I know there's some trauma alert criteria out there for elderly. I'm not aware of any particular trauma alert criteria that anybody has for motorcycle crashes. We could query that, and I could find out, but I'm not aware of anybody who has anything else specific to that.
Okay. Dr. Nelson, anything to add to that?
The only thing that I know of is that some EMS agencies do have special handling instructions based on types of helmets, whether certain types of helmets are to be removed or to be left on. Beyond that, I don't believe there are any agencies that have specific motorcycle crash protocols in place.
Okay, great. Dr. Sobowale, anything in addition to those statements?
Well, not in this area, Central Florida. I think it still comes down to kind of looking at the scene, looking at the patient. For example, the patient separated 300 yards away, 300 feet away from the bike. That's an indication of high speed and separation that kind of triggers an acute awareness. but there are no protocols that we have at this point in our region regarding motorcycle crashes.
There's been a number of questions about the second case, actually. Patient number 2 that was presented. I think Jerome R. best sums up what several people have commented on. And Dr. Block, if you're there, I was hoping that you could take a stab at this question first. Question is, since case number 2 was paramedic discretion only and no real critical interventions were done by the trauma center, do we as panelists think that there may have been a difference in outcome if she had been transported to a non-trauma center, or since there were no interventions, was a trauma center transfer really necessary? And Jerome adds on that this question goes along with Dr. Nelson's comment about how paramedics using paramedic discretion are often chastised. Dr. Block?
Yeah, I'm here. I'm sorry, I'm a little confused because of your indication that there were no critical interventions done when she had a large section of her liver controlled for hemorrhage.
Oh, this is patient number 2.
Case number 2.
Case number 2.
Yeah.
This was the head injury and the ankle fracture.
Gotcha. Sorry.
Which was a big issue.
Well, I would echo the concerns about paramedic discretion. The thing that is difficult is for the team that's in the emergency room to see what the EMTs are seeing in the field. That being said, I think what Dr. Nelson said is critical, is that when any trauma patient is being transferred, the question is why is there an index of suspicion? And so if the paramedic indicates this patient is showing signs of a significant intracranial hemorrhage with agitation, or the other patient is having focal abdominal pain, which is unusual, those provide that additional information that the team can assemble itself better. And the issue there is that patient with the brain injury, had they been taken to a non-trauma center, would almost certainly have been transferred to a trauma center thereafter because of the risk of deterioration for which a neurosurgeon would be necessary. So it's not a matter of accepting complete over triage, and there's always an argument about what that level of over triage should be. But the patient did have appropriate interventions and had to be monitored should the patient deteriorate.
Right. Dr. Nelson, would you like to perhaps add anything to that?
Yeah, I'd just like to add on that from an emergency medicine standpoint, had this patient come to a non-trauma center and they found that hemorrhage when they did the CAT scan, absolutely this patient would be transferred to a trauma center. And the thing is, all of us in emergency medicine and in trauma have seen patients that present with rather subtle findings initially on CAT scan and then proceed to rapidly go downhill. And if that were the unfortunate outcome in this particular case, we would want that patient at a trauma center with neurosurgery readily available. So I think it was important to get this patient to a trauma center. And again, I congratulate the EMS personnel for picking up on these subtle findings, the agitation, and combining that with a good scene survey and a good evaluation of the patient and making the right call from the scene. That was an excellent question from Jerome.
Dr. Byers, anything to add to that?
Yes, I would like to add that, because I think that the intervention, other than the ongoing monitoring because the patient had a risk of deterioration with an intracranial bleed, was the fact that the patient could have long-term sequelae from a minor traumatic brain injury with difficulties at work, difficulties in school, emotional difficulties, and relationship difficulties. And the patient was triaged to rehab where these things could be addressed and intervened upon, so to have a minimal outcome problems with the patient in the future.
Okay, very good. The next question is Dr. Sobowale. If you're there still, I was hoping to ask you this one. Coming from Blake A., and this is actually a rural trauma question. In other words, motorcycle crash management for rural trauma EMS. Blake writes, coming from a very rural area, rural department with many backwoods areas, not easy to get to. in your judgment, would it be worthwhile to consider flying motorcycle trauma patients to trauma centers on a regular basis when transport on ground could mean a possible delay of 30 to 40 minutes? And clearly for patient number 1, Dr. Block's patient, that 30 or 40-minute delay, let's say if the patient needed that long to be transferred, might have made a big difference.
Boy, that's a loaded question because, in looking at the overall picture, you want to use your helicopter transport judiciously. You want to use it appropriately. The other side of the coin is you get to the scene and the patient, not necessarily fulfilling criteria for trauma alert, still looks, quote, bad, end quote. You sometimes may need to do that. I would not say you do it all the time. I would say that you look at the patient, you look at your situation, physiology, and then if you feel that the patient needs an expeditious transfer, for example, a single femur fracture that's, hard to control the bleeding from, for example, may not trigger trauma alert yet in an 18-year-old, but you wait long enough on the ride and the patient decompensates. So you may want to use your judgment at that point and say, this looks bad, let's get the helicopter in, and then you communicate that to the flight crew, and so they are aware that you're transferring not as a trauma alert, but because you feel that expeditious, transport is required for this patient. So I think, again, using your judgment, that's the most important part. And I keep using the word paramedic judgment, not discretion. I think it's judgment.
Great. Dr. Block, anything to add to that?
No, again, I think it's well said about discretion versus judgment in terms of making an assessment with specific markers. Where I think where probably there's some pushback from treating physicians and nurses is when the paramedic trauma alert or discretion judgment is done. And we ask why, what was the concern, and the answer is something of it was just the whole thing. Providing more detailed information such as 2-foot intrusion in the vehicle, abdominal pain, agitation, things like that, give us a little bit of an insight into what the EMT is thinking, and also allows us to focus attention to those critical injuries early on.
Great. Dr. Nelson, what are your thoughts?
Well, I would say that the use of air medical assets, like everything in medicine, has to be based on the risk versus benefit ratio. We know that our air medical assets are limited in the state, although Florida does enjoy better air medical availability than most places across the country. We still don't want to use those assets unless we think the patient ultimately will benefit from the use of that more rapid modes of transport from a rural area. So just to kind of echo the trauma surgeon's answers, I think that each case is individual, and you always have to weigh the risk to the patient of air transport versus ground transport, and each case has to be decided on a case-by-case basis.
Well, very good. The next question, speaking of loaded questions, I'd like everyone to take a stab at this, starting with Chief Richter. The question is from Greg W., and the question is, would the state reconsider the use of paramedic judgment as a red or blue criteria? Chief, what are your thoughts?
Well, I know we just went over recently all the trauma alert criteria and compared it to other states and the CDCs and a lot of different agencies or organizations or states and stuff. And I think it's still there. It's not there in black and white, but it's still used, and I think it's an important part. That's more of a question for the trauma groups to get that done. But I know Dr. Nelson was on a lot of those meetings too. He may have some more insight on that, but I think we kind of felt that the trauma alert criteria was working in the state of Florida pretty well and didn't need a whole lot of revamping.
Dr. Nelson?
This is Dr. Nelson. I would echo that Florida has actually more stringent trauma alert criteria than most other states. And in fact, our criteria are somewhat different from the nationally recommended criteria in that we have additional criteria in there that is not found at the national level. Paramedic judgment should remain as kind of the trump card when the patient doesn't clearly meet any other criteria, but the mechanism of injury and the patient's physical exam or complaints indicate the potential for a severe injury. So I would certainly agree that paramedic judgment needs to be used judiciously, but nonetheless should definitely stay as a trauma alert mechanism in the trauma transfer protocols.
Dr. Byers, what are your thoughts on that?
My thoughts are that paramedic judgment is vital, I think, as a triage criteria. However, I agree with Dr. Nelson that I think it should be used when you don't have obvious physiologic mechanism or anatomic criteria that presents, because I think that if you don't have the other criteria, the evaluation of the patient could, there's a risk would not be as detailed. That being said, I think that I would use this as a time to plug MSTARS and hope that when we get our trauma registry intact and we have everyone on MSTARS and we can enrich the data in MSTARS to include the trauma criteria, I think we can do a very good study and we could actually answer these questions with some factual information.
Dr. Sabawali, what do you think? Can MSTARS play a role here?
Well, let me go back to the original question,
okay.
And that is, do we consider the use of paramedic judgment as a red or blue? Right now, actually, it's a red, which means that paramedic decides and calls it, and the trauma alert system is activated. Okay? So right now, it's considered, it is a red. That's how it's utilized. Asking, okay, what Greg is asking is, should it be a blue? So if you got a femur fracture and you're not just sure where you think something needs to be done, you add paramedic judgment, now you got two blues, and that's a red, and that's activated. Right?
Right.
So that's the question that I'm hearing, to which I say, segue to the second part, which is we need to have MSTARS, we need to look at it objectively so that when we make a decision that's going to affect everybody in the state, we're doing it with some data behind it. So I would agree with Dr. Byers about looking at this through a database that's going to kind of take out all the emotions out of it and give us objective data that says, yes, it works, or yes, it works as a blue, or yes, it works as a red.
Great. Dr. Block, what are your thoughts on that?
Yeah, of course, I'm going to agree that anything that is being attempted should be analyzed for efficiency in terms of the data, and the outcome measures are important as well. I do appreciate the one person's question about, no critical interventions were made on the patient. And one of the difficulties within the state of Florida has to do with the ability of the paramedics to define destination at a trauma center where all capabilities are available, and we have opportunities to take care of any future problem. So a patient that may not meet trauma alert criteria but has potential for injuries that could get worse and need those capabilities, the field team has no opportunity to bring them to a trauma center as opposed to a community hospital through any mechanism except for trauma alert. So the other opportunity there would be to show that, yes, paramedic discretion can be helpful, it can be applied, and that these patients could be transported to a trauma center preferentially, just not as a trauma alert with the expense and risk of activating the entire trauma team. So I'd be very supportive of any kind of database that would analyze the results of our paramedics and EMTs' skills at predicting that.
Thank you very much. I think we have time for one more question. Dr. Byers, I'd like to ask you this. It's from Michael L. In fact, the question is, would you consider massive road rash as a criteria for a trauma alert and to treat road rash as you would a burn?
Oh, that's a very interesting question. Here, although road rash is extremely, as Corey Richter mentioned, is extremely impressive as an injury, and it does act somewhat as a burn, that it's rarely, unless there's a complete avulsion injury, it's rarely full thickness. We on the trauma service take care of these injuries. They don't necessarily go to the burn service. However, if it is an extensive part of the body surface area, the patient would be at the same risk that they would from a burn injury. So I guess what I would suggest is that you use your rule of nines. You calculate out the percentage of burn and see. But in most cases, this can be managed with local wound care, is my experience.
Very good. And, well, that looks like we're up to 1:30. That's all we have time for today. Please forgive me if we didn't have a chance to get to your questions, but you can always email us and email your questions to Tara Irani, and we'll certainly be able to get back to you. Certainly I'd like to thank everyone for participating today. Post-survey evaluations will be available to complete in a moment directly on Live Meeting. The post-survey must be completed, please remember, by each individual in order for the participant to receive 2.0 CEU credits, even if the presentation was viewed in a group setting. And those of you who lead a group viewing do need to submit an attendance sheet, which can be downloaded in the handout section to Tara Irani at tirani@med.miami.edu. Thank you all again, and I'd like to turn it over to Dr. Byers for just some closing comments.
I want to thank everyone for participating in this webcast today. I think that we always learn from everybody. We learn from each other, and this is an attempt so that we all can cooperate in saving lives of motorcycle crash victims. I thank the audience for their interest and participation and their questions. And I would just want to reiterate that if you are viewing this webcast in a group, you will have to sign on individually to do your post-survey and get your CEU credit, as there will only be the ability for whoever signed in on the webcast to do the post-survey. So if you're viewing this as an individual on your own computer, you can go ahead and do the post-survey online as it is posted. However, if you're viewing it as a group, you're going to need to go to your own computer and sign in and do your post-survey. Thank you again to everyone who was instrumental in getting this done, and thank you very much for our presenters and all the participants. Good afternoon, and ride safe.